Assalamu alaikum. This video is about peripartum or postpartum cardiomyopathy. It is important for obstetricians to have awareness of this very serious medical condition. The management is multidisciplinary, involving obstetricians, cardiologist, intensivist, pediatrician, and anesthetist. Peripartum or postpartum cardiomyopathy is the most common cardiomyopathy in pregnancy. It is defined as an idiopathic cardiomyopathy which presents with heart failure secondary to left ventricular systolic dysfunction, and it usually presents towards the end of pregnancy or in the months after delivery. Usually, there is no other cause of the heart failure, and important to note that peripartum or postpartum cardiomyopathy is a diagnosis of exclusion and can only be done after all other causes have been ruled out. The most significant factor about this disease is that even though the left ventricle may not be dilated, but the ejection fraction is nearly always reduced below 45%. Remember that ejection fraction in normal healthy patients is anything between 50 to 55%. And so if an ejection fraction is below 45%, it means that it is abnormal. And if it is below 40%, it means the heart is failing. Let us talk about the patients in whom we will see this disease. It is more common in women who are older than 30 years, who have a Black indigenous background, are multiparous, who have preeclampsia or hypertension, and those who smoke or are malnourished. The severity of symptoms in patients with postpartum cardiomyopathy will be classified by the New York Heart Association, and all candidates should remember to know this system of classification well, as it applies to all cardiac problems. In class 1, the disease will have no symptoms. In class 2, the patient will have mild symptoms, and these may only be apparent when the patient is doing extreme exertion. In class 3, the symptoms will present even with minimal exertion, and if in class 4, the symptoms will appear at rest. So this classification will tell us about the severity of heart disease and how seriously we have to approach the problem and relieve the symptoms of the patient. The exact cause of peripartum is uncertain, but we generally see it in a particular group of patients. There are no national prevalence rates for our country, and the condition is rare. Approximately 1 case will occur in 1,000 pregnancies. But obstetricians should always maintain a very high index of suspicion for pregnant patients who are having difficulty on exertion, and careful history should be taken for early referral in cases of any cardiac symptoms for disease. The morbidity and the mortality associated with this disease will be very high in those countries where the health systems are weak and the referral processes are also weak. And the morbidity and mortality here can be as high as 50%. If a patient has this disease, then how do we know that this patient is at extremely high risk? The risk factors include a very low ejection fraction below 30% and left ventricular dilatation and the black race. It has been seen that in the United States of America as well as in South Africa, women who have this background will have a higher mortality. It's important to note that if a patient has been diagnosed with postpartum cardiomyopathy, then there is a higher risk of recurrence with subsequent pregnancies. And this risk of recurrence may be as high as 50%. The risk will be much more in women who have a black background or who have persistent left ventricular dysfunction with a lower ejection fraction. So it's also important to note that these women have a higher rate of obstetrical complications. So the risk of premature delivery and of threatened abortions may also be higher in such patients who have persistent left ventricular dysfunction. And it has been noted by the European Society of Cardiology that women who have very severe classification of heart disease, they should not be allowed to have pregnancies. So this classification is actually the classification of the World Health Organization, which has been modified for classifying maternal cardiovascular risk application. So the risk 4 is the highest risk that can be denoted to a patient, and the patients who have history of cardiomyopathy and who have persistent left ventricular dysfunction and who have persistently low ejection fraction of the left ventricle are not allowed to have subsequent pregnancies because of the risk of death in subsequent pregnancies. We all have seen that patients who are pregnant will have a lot of symptoms, and some of these symptoms will mimic cardiac disease. For example, the patient may complain of dyspnea, of dizziness, of orthopnea, decreased exercise capacity, and these are often normal for pregnant patients. Patients may also complain of mild dyspnea upon exertion, but on the whole, obstetricians still need to have a very high index of suspicion for underlying disease in pregnant patients, especially if the symptoms become progressively worsened and if the patient is having difficulty doing ordinary jobs. Generally speaking, it is not usual to have an early diagnosis of peripartum cardiomyopathy, and the patients may not show any indication of the syndrome until delivery has occurred. Sometimes patients are detected at the time of elective cesarean section because the patient may have high blood pressure, may have an abnormal rhythm of the heart on ECG, and may have low SpO2 levels. Sometimes the patient is discovered because they may collapse during the peripartum period. What are the symptoms of heart failure, and what are the symptoms of respiratory failure without any previous signs or symptoms to alert the physician? If there is new or rapid onset of the following symptoms, it requires prompt evaluation. If the patient is complaining of cough, if she has difficulty in lying down flat in bed and becomes breathless, if she has paroxysmal nocturnal dyspnea, if she is constantly fatigued, has palpitations, is coughing up blood, has chest pain or abdominal pain, then you should be alerted and get a cardiac opinion if possible. The physical findings in during pregnancy are not often appreciated by the obstetrician because generally these special tests are not done by obstetricians. But however, we do know physiologically that in normal pregnancy, respiratory tidal volume is increased and patients will hyperventilate with a normal rate of respiration. Even in normal patients, cardiac auscultation will reveal a systolic ejection murmur at the lower left sternal edge. And the pulmonic arterial flow murmur will become quieter during inspiration. So generally, these findings are not often appreciated by obstetricians because they do not do these examinations of patients. However, peripheral edema may occur in approximately 1/3 of healthy gravid patients, but if there is a sudden change in swelling and it is bothering the patient, then it should be investigated. So in a patient with cardiomyopathy, the signs of heart failure are the same as those in non-pregnant patients with systolic function. There will be tachycardia, there will be decreased oxygen saturation, and the blood pressure may be normal or it may be elevated. And the elevated blood pressure may be more than 140 millimeters systolic or more than 90 millimeters diastolic. Patient may sometimes even have hyperreflexia, and this can suggest preeclampsia, especially if the patient is already hypertensive or she's a primary gravida. Other signs of heart failure which may be appreciated by cardiologists or even by an obstetrician is elevated jugular venous pressure, cardiomegaly on chest x-ray, and third heart sound, as well as worsening of peripheral edema, ascites, and arrhythmias with embolic phenomenon. On careful palpation, you may detect hepatomegaly along with the ascites. So if a patient is presenting with cardiac symptoms that are suggestive of cardiomyopathy or some other cardiac disease, what is the differential diagnosis? The differential diagnosis, most important that has to be excluded, is of preeclampsia. And this is the one that mimics this disease the most commonly, but it can be excluded on the basis of history, the physical examination, and investigations. The differential diagnosis will include the following apart from preeclampsia: aortic stenosis, severe hypertension with a history of hypertension in the past, mitral stenosis. Often there will be a past history suggesting that the patient has mitral stenosis and is under care or even has had. Other differential diagnosis will include some stress like pyelonephritis or other infections which are secondary to using corticosteroids with pyelonephritis or using tocolytics such as beta agonists and magnesium sulfate. They can also produce non-cardiogenic pulmonary edema during pregnancy. A history of raised blood pressure with positive labs, a history of pulmonary embolism with respiratory failure with DIC. Again, pulmonary embolism is not something easy to diagnose, but patients will often present with very similar symptoms, and we should keep this on as one of the diagnoses when we are managing the patient for the purpose of either diagnosing or excluding. If the patient has some kind of an infection and it is very toxic, it has now become generalized, and there is a metabolic disorder resulting from the infection, again the patient may present with the cardiac symptoms. So what about tests that are specific for the diagnosis of cardiomyopathy? How do we exclude other conditions and how do we confirm that cardiomyopathy is present? One of the tests that we do often for cardiac disease is troponin levels. However, troponin levels have very poor sensitivity in cases of peripartum cardiomyopathy. So often you will do the test, but the test may not come back positive. And even if it is positive, the sensitivity may be low. Other laboratory tests which will differentiate cardiomyopathy from preeclampsia are important, and these will include serum creatinine level, which will be greater than 0.8 milligrams per deciliter in cases of preeclampsia, a hemoglobin level which will be above 13 grams per deciliter due to hemoconcentration in preeclampsia, elevated liver enzymes in preeclampsia, and thrombocytopenia in preeclampsia, and none of these will be positive for cardiomyopathy. Similarly, in preeclampsia, other positive findings on lab investigations include a urine dipstick result which is positive, more than 1 plus positive, and decreased 24-hour urine creatinine clearance, and more than 300 milligrams of proteinuria evident on 24-hour collection. What are the other tests that we do to diagnose peripartum cardiomyopathy? These include ECG and rhythm monitoring. ECG in patients with cardiomyopathy may show sinus tachycardia or rarely atrial fibrillation. There may be other non-specific findings which will be of interest to the cardiologist and will be interpreted by the cardiologist. Chest radiography is essential for such patients for the diagnosis, because we want to have a look at the heart as well as the lungs. And when evaluating a patient with new onset dyspnea or tachycardia or hypoxia, then just a radiograph can be done by abdominal shielding to detect pulmonary edema. So generally the fetal radiation exposure will be well below the accepted limit for fetal radiation during pregnancy. And in cases of cardiomyopathy, you will find an enlarged heart with fluids in the lungs. The heart may not be enlarged in all cases, but generally this finding is very positive and correlates with cardiomyopathy. The cardiologist may decide to do cardiac catheterization and invasive hemodynamic monitoring, and this can be done safely during pregnancy. And so the obstetrician need not worry about this. So generally the obstetrician may be the first person who will identify the problem, and the general treatment approach in such cases is that first of all, you have to have a high index of suspicion. If the patient is suddenly complaining of symptoms which are suggestive of cardiac disease, or if the patient has sudden swelling of the extremities and the abdomen and the face. So if the patient is seen in the outpatient, you should immediately admit the patient in special care, put up a cardiac monitor, give the patient 100% oxygen at a rate of 10 to 15 liters per minute, and start an intravenous line, and urgently contact the cardiologist for urgent referral. If you have a fetal-maternal unit, and if there is a physician in the fetal-maternal unit who has experience of addressing medical issues during pregnancy, then you can refer the patient first to the fetal-maternal specialist. So once the patient is under the care of the cardiologist, then they will make decisions about where the patient is going to be kept and how the patient is going to be managed. From an obstetrics point of view, there is no need for total bed rest unless and until it is an indication because of the severity of the disease, because the increased bed rest will then increase the risk of deep vein thrombosis or venous thromboembolism. The cardiologist will then decide on the treatment of the patient, and this treatment may include diuretics and beta blockers and many other things, including anticoagulants and antiplatelet agents. And the important to know about the anticoagulants and the antiplatelet agents when you are considering delivering the baby. The route of delivery may be vaginal if the patient is hemodynamically stable, because vaginal delivery puts less stress on the patient's metabolic system and has a much lower incidence of endometritis as well as pulmonary embolism as compared to cesarean section. However, it all depends on the patient and upon the urgency of delivery, and also depends upon the baby and whether there is any urgency of delivery for the baby. How can we care for the patient when she is in the process of labor? We should know that every time the patient has a uterine contraction, the blood is pushed into the circulation and the cardiac output may increase from 15% to 20%, and it can be as high as 45% from the baseline. So every time the uterus contracts, there is stress on the heart. The pain with the contractions can also increase the metabolic demands. Initiating early regional anesthesia and assisting the second stage of labor will be helpful in countering the physiological responses and helpful for the heart. After delivery, the contracted uterus will squeeze about 300 to 500 ml of blood into the systemic circulation. This transfusion, autotransfusion, along with the release of the inferior vena cava compression by the gravid uterus, will lead to an increase in the venous return of the heart. And therefore, this will again further load the heart and put a greater load on the heart. And this is the reason why many of these patients present in the postpartum period, because now the heart is being overburdened by the autotransfusion from the placenta and the uterus, as well as the lack of the venous compression by the gravid uterus. And so these patients are more likely to present with symptoms in the postpartum period. So again, C-section will be indicated if there is any maternal or if there is any fetal. It's important to understand that in the post-delivery period, what are the considerations in terms of the baby being breastfed. So we have to discuss this with the cardiologist, and we have to put the patient on drugs which are not going to harm the baby. There is some concern that ongoing breastfeeding may actually affect left ventricular dysfunction. So in those cases where the dysfunction is very severe, breastfeeding cannot be done, is discouraged. What are the complications of peripartum cardiomyopathy? The complications can include hypoxia, thromboembolism, progressive heart failure, arrhythmias, and so all these are complications that can only be managed by cardiologists in a special care unit. It's important to understand that patients who have peripartum cardiomyopathy may often be confused with eclampsia, and so important to diagnose eclampsia and to make sure that the patient does not have eclampsia, and also important to make sure that the fetal complications may not occur because of the hypoxia or hypoxic conditions. So patients cannot stay in the labor room once they have been diagnosed to have cardiomyopathy and must be of the cardiologist. Once the patient is fit enough for discharge and and can go home, then again the patient obstetrician cardiologist, and then should be under the care of a high-risk obstetrician or a maternal. And patient should be given very strict family planning advice until a decision can be made about future pregnancies, because the patient should be watched for at least 3 to 6 months postpartum to evaluate the left ventricle function or dysfunction, and patients who have persisting left ventricular dysfunction will not be allowed to go ahead and to have another pregnancy. With this, we come to the end. Very much. Goodbye.